In order to correct alignment, you have to correct the soft tissue restrictions. Very commonly, in almost all cases, it's pec minor, frequently pec major, subscapularis as well, latissimus dorsi, and we'll see on Jim's patient that I'm going to be examining in a little while if that's the case. But again, I showed the cervical lordosis, thoracic kyphosis that we frequently see in these patients. Thoracic hypomobility is something that the physical therapists talk about all the time, and that's very, very key to try to eliminate that early. This is releasing pec minor, doing it passively, and in my teenage athletes, I teach the parents how to do this in the office. It actually feels good. I mean, think about what you do when you feel too tight across your chest. You pull your shoulder blades back and down, and you stretch a little bit. You do it in the operating room after you've been scrunched up over the table. And then if you have a therapist that's good with manual techniques, they'll do the releases as well. But one of the things we've been using a lot is the foam roll, because they cost all of $20 or $25. The patients can do it on their own, and it's very important to make the patient take responsibility for their own alignment, because they're not going to have much in the way of benefits with physical therapy with most insurance companies. So here's a nice stretch for pec minor, that if you just have the patient use the foam roll vertically and just let the arms drape to the side, it'll really stretch pec minor very nicely. This works on the thoracic hypomobility. You can roll on the foam roll for the lats here and for pec major there. So you can have the patient doing that freely, and it substitutes for the hands-on therapy that they may not be able to get. So now we've lined up this patient, and we want to make sure that we're working on her core strength, because as you know from the kinetic chain, you have to have proximal stability before you can have accurate distal mobility. So here's on this patient, once she gets lined up, now you can have her start to do core work and work on balance and work on rotation to do lumbopelvic and core stabilization. This is not so easy to do. And what you'll find is a lot of your throwing athletes will be incapable of doing this. Exercise progression. This is my biggest battle with the physical therapists. The physical therapists feel that at 3 weeks, the patient should have hit a certain landmark, at 6 weeks another, at 12 weeks another, and they're treating the chronology, they're not treating the function. And I have a big problem with this, occasionally even with our physical therapists, who are some of the best physical therapists around, because it's sort of ingrained in school. So what you have to remember is that different patients learn at different rates. I mean, for those of you who play golf, not everybody learned how to hit their 7-iron in 2 weeks. Some people took 2 months, some people took 2 years. So everybody's a little bit different. Sometimes older patients sometimes can't focus. Heck, teenagers can't focus. So you have problems with that. Fitness level is going to have an effect. Diabetics aren't going to get their motion as quickly, and they're not going to be able to rehab. And then there are people that the physical therapists refer to as motor morons. They're just not going to be able to learn it. So everybody learns at a different rate, and the important thing is functional progression and acquisition of that function. Remember that quality is more important than quality. You want to make sure that it's being done properly. So the last thing you want to do is tell the patient they should be doing 3 sets of 10 of anything, because what they should do is do it until fatigue. And the way you know that the patient is fatiguing is they have bad form. And if they do it with bad form, then there's going to be a muscle overload, and you're going to wind up keeping the joint inflamed. So you're better off, when a patient says, I don't have time to do all those exercises, yeah, but they do have a lot of time to do things frequently. So you have them doing their exercises while they're sitting in the car, position their hands on the steering wheel and do some scapular work while they're sitting in the car, and they do a little bit frequently. You want to begin with submaximal and progress to maximal effort. So in general, we'll teach them to fire the muscle in isometric and then have them fire it eccentrically, and then ultimately we'll let them put a concentric load on it, and we progress from closed to open chain exercises. The phases that I'm using now are isolation, integration, and functional. The isolation phase, you teach the patient to isolate the muscle so that you can correct the malposition or malalignment. You've got to figure out what's weak, what's tight, what's short, what's strong. Then you integrate the muscle train the muscle in a coordinated fashion so that you have a synchronous pattern of motion. And then when you can do that, then you move into the functional phase, and you can establish normal functional movement patterns and the proprioception that Giovanni talked about. And that will restore your dynamic stability. So in the isolation phase, you want to correct posture and the position of the scapula. This is number one. You want to lengthen the short and tight muscles, strengthen the weak muscles, and you want to start addressing joint hypomobility. You want to start developing scapular awareness, and you want to start working on the quality of motion, that is the scapulohumeral rhythm. So here's an early exercise. We teach this actually in the office before we send the patient out. All it is a sternal lift. And you have the patient just bring their chest up, and the scapula in general goes into position, but I have the patient do this in the mirror so they can start seeing where the clavicles belong and is the shoulder too high or too low. And then the next phase for this exercise would be what Ben Kibler calls the robbery position, where the arms come back and you have them do retraction, depression, again, if that's called for. You tailor the exercise to the patient's abnormality. And another way of doing the same exercise is wall angels. And this way, if the patient is having trouble identifying where their scapula is, they can feel it against the wall. The cheat that the patient uses when they can't do this properly is they dorsiflex their wrists, and their forearms come away from the wall. You can start this as an isometric, holding it at 30, 45, 60, and then up to 90, and then work your way up the wall. And then this is a really nice exercise. The spine therapists use this quite a bit, actually. It's an external rotation exercise, but you've got to have the chest in position, and then ultimately I got him to get his neck in position, but this was a struggle for this guy because of his alignment issues. But if you don't do the exercise in the proper position, then ultimately you'll just make things worse. And then you want to incorporate the other body segments from the kinetic chain, the core, trunk, and lower extremity, and you want to progress from simple movements to complex movements and transition to strengthening endurance exercises. So here a lawnmower starts, and now this is really a scapular positioning exercise, and now we're bringing in the legs and the core. And then the next phase, you would start adding, you would go to rubber tubing, and then ultimately you would go to weights. And then eventually you would have the patient doing more functional things for the specific activity that they choose. And then functionally, now you want to get the whole body moving, simulating the movement either for the sport or work or whatever function you're trying to get them back to do, and you start increasing the frequency, intensity, and duration of the exercises. So in a thrower, you would eventually go to this, but watch how he cheats after a couple of reps, and his core is fatiguing, and this shoulder starts to swing out, and the body is rotating. And that's what a lot of throwers do, and that's why you see a lot of pitchers with low back pain. And you can almost identify them by watching their throwing mechanics. And if you want to think about this in terms of the post-op rehabilitation phases, because it's virtually impossible to give you a program that's good for non-operative and post-operative for all of the different procedures, classically it's broken down into acute, recovery, and functional phases. But think about in the acute phase, you want to protect the repair post-operatively. In the early recovery phase, you want to start preparing the shoulder for the motions that you're going to have. Then you progress it, and then you start to get into the performance phase. Thanks for your time.
Giovanni, are you going to go over with him?